First, I would like to welcome Dr. Khadija and Professor Antonio. Thank you very much for participating in this session. Dr. Khadija, she's internal medicine consultant in diabetes unit in Rashid Hospital in Dubai. And Professor Antonio, he is the president of European Association for the Study of Diabetes. Thank you very much for joining us today, Professor. We will start today with Dr. Khadija for the next 30 minutes, and then we will move to Professor Antonio, and after that we will have 15 minutes for question and answers.
So, good evening, dear colleagues, ladies and gentlemen. Assalamu alaikum. It really is a distinct pleasure and an honor, actually, for me to be part of this webinar. I hope you can see my slides. Let me just get it onto the PowerPoint mode. Okay, there we go. So what we'd like to do today is talk about the risk of COVID-19 in patients with diabetes and some of the mechanisms for poor outcome. So to start with, these are my disclosures, and I don't have any conflict of interest in regards to this presentation. And our learning objectives will be to first highlight the epidemiological association of COVID-19 infection in individuals with diabetes. I will then try and discuss in more detail some of the mechanisms for the poor outcomes that we see in our patients with diabetes. Then explore this link between COVID-19 infection and the concept of new onset diabetes. And then I'll review just some basic principles for diabetes care in an ongoing pandemic. So a year on, we know quite a bit about the virus, but we're still not certain about which is the likely animal of transmission. Is it a bat? Is it a rodent? We're still trying to figure that mystery. But what's important is that we now realize that this virus is able to gain entry into the human host through the spike proteins that are shown here on the figure, and they latch on to the ACE2 receptor in order to gain entry into the cells. We've all become familiar with the illness course. We know that from symptom onset, maybe about 5 to 10 days, there's an incubation period followed by an acute mild phase. And for some individuals, they may progress into an pro-inflammatory phase with development of ARDS. And we know that some of those patients may actually recover, whereas some patients may not do so. So a lot of efforts are being carried out in order to get the patients probably to remain in this kind of acute phase and then recover, rather than progress into a persistent illness to require either intensive care, admission, or have an increased mortality. So the other thing that we've come to appreciate is the fact that COVID is not just a pulmonary disease. It is really a multi-system disorder. And in some patients, we've actually seen that they have a lot of these multi-organ defects. In the interest of time, what we'll try and do today is just concentrate on the endocrine effect and specifically look at the effects on diabetes. So if we look at some of the risk factors for severe illness, and what I've tried to do here is look at it in terms of the evidence. So the stronger evidence coming from the meta-analysis and the systematic reviews shows that there's those patients with underlying malignancies, those with cardiovascular diseases, chronic kidney disease or chronic obstructive pulmonary diseases, obesity, pregnancy, and patients with type 2 diabetes are really at risk for the development of severe illness when they have the infection. Based on case control and some cross-sectional studies, we know that these group of individuals may also be at risk for severe illness. So the first sort of Twitter feed that caught my attention was from the Oxford University way back last year in April. And what they did was they put out this Twitter feed and they said people with diabetes appear to be at an increased risk of having a more severe COVID-19 infection. But at the time, the evidence quantifying this increased risk was highly uncertain. And the extent to which the clinical and demographic factors that moderate this relationship between diabetes and COVID-19 was quite unclear because we didn't have the data. We were just starting into the pandemic, but now we have much more information on that. So kind of the first few questions that we asked were, are people with diabetes at an increased risk of infection with the SARS-CoV-2 infection? And we know that the evidence to date is quite weak and the associations really have not been proven. The second question is, does infection with COVID-19 yield a worse outcome in people with diabetes? And I will show you the evidence that suggests that yes, indeed, people with both type 1 and type 2 diabetes tend to have worse outcomes when they develop this infection. And this, of course, may be related to the hyperglycemia. It may be, of course, indirectly related to ACE2 receptor deficiency as well. So we'll try and look at that evidence more closely. So to reiterate then, we know that from the epidemiological data that's available so far, it does not support the fact that people with diabetes are at an increased risk than the general population, but it seems clear now for patients with diabetes, particularly when they're not well controlled, they have got higher risk for complications and a higher mortality. And in fact, the first to sound the alarm bells were the Chinese when they reported in JAMA on the case fatality rate, and they showed that the case fatality rate was much higher in those individuals with pre-existing comorbidities, and diabetes was listed as the second one with a case fatality rate of about 7.3% and 10.5% with those with cardiovascular disease. And then in Diabetes Care, following on, they also published this article that reiterated that diabetes is a risk factor for poor early outcomes in patients that are hospitalized with COVID-19. And if we look at the checkered boxes, these are the patients with diabetes, and the dark gray bars are the patients without diabetes. And what you appreciate is the fact that whatever their BMI category, so if you look at those who are normal weight, those who are overweight or obese, if you have diabetes, your likelihood for intensive care admission, your likelihood for the need for mechanical ventilation and mortality is much higher in those with diabetes as compared to those without. Then there was the Coronado study out of France. Here, this was different from the two studies that I've just mentioned in that this was a prospective study. They had 53 hospitals in France where they grouped the patients. So they had more than 1,000 patients that were recruited. And what they did was look at the follow-up from admission to day 7 for the primary outcome and look at death or mechanical ventilation. And what they actually demonstrated was the factors that were independently associated with, say, the use of mechanical ventilation at day 7 was the patient's BMI. So the higher the BMI, the more likelihood that the patient might end up on a mechanical ventilation. And then the factors that were independently associated with death was those that had diabetes with who are elderly and had evidence of both micro and macrovascular complications. We were able to look at our own patients, and what we found as well in our cohort is those patients that presented with COVID-19 infection and were diagnosed with new diabetes actually had more severe presentations of the disease shown here. So the blue are those that were diagnosed with diabetes during admission for COVID-19 versus the orange that were already previously known to have diabetes. So This is kind of like a summary which shows the COVID-19 outcomes with pre-existing diabetes based on cohort studies, retrospective studies, and meta-analysis. And when we can see is that the risk for severe disease and mortality is in the order of about 2 to 3%. So is it that everybody with diabetes is at an increased risk for these complications? In fact, what is really emerging from the data are common themes. We know that men are disproportionately affected, people with increasing age, so the elderly, the higher the BMI, presence of cardiovascular disease or risk factors also increases the risk for these complications. In places like the US and in the UK, they've also shown that certain ethnic minorities have a higher risk for developing severe COVID-19 infection. And then certainly the duration of the disease, poor glycemic control is also associated with an increased severity. In addition to having other diabetes complications such as chronic kidney disease or retinopathy or foot problems. Is there a difference then between those with type 1 and type 2 diabetes? And this was elegantly answered in the paper from the United Kingdom. And they had a whole nation study where they were able to look at the outcomes and mortality in patients with both type 1 and type 2 diabetes. And again, you appreciate in the red the patients with type 1 diabetes, and they in fact had a higher mortality than the patients that had type 2 diabetes compared to the overall population. What we also appreciate is the fact that this is a disease that disproportionately affects the elderly. So when the age is above 60, the mortality rates go up sort of exponentially. So what is it about hyperglycemia and infections? We know that with long-standing diabetes and the presence of hyperglycemia, it actually impairs the innate immunity, thereby rendering most patients with an increased risk for infections. And we also know that the innate immunity is actually the first line of defense against any infection, and particularly viral infections such as COVID-19. So we can see here the glycemic control and infection risk in individuals that are aged 65 and above, and in those that are younger as well. When the mean hemoglobin A1C is higher, you have a greater risk for hospitalization when you have infection and a greater risk of mortality as well. And then when we look specifically at COVID-19 infection, we can see that the inflammatory markers, the C-reactive protein and interleukin-6 are much higher in those patients with diabetes compared to those without diabetes. So looking at that in a more greater detail, we know that there's quite extensive immune dysregulation in patients with diabetes. This may be associated with the fact that we have obesity in a lot of our patients with diabetes. And what these adipocytes, enlarged adipocytes, do is that they produce a lot of pro-inflammatory cytokines. And what you find is you also get a lot of these dysfunction in the T regulator cells, and that may also be responsible then for the severity of the infection. If we look at it in a little bit greater detail, we know that the infection with the virus causes this increase in the inflammatory cytokines. You might have an increase in the interferons as well. There certainly is an increase in the reactive oxygen species and interleukin-6. There's also activation of the renin-angiotensin system, and there's diabetes being a procoagulant state. You may have also increase in fibrinogen and D-dimer. So when you have an increased of these inflammatory cytokines, it can lead to direct lung fibrosis, or it may lead to interstitial and vascular injury, thus causing excessive permeability. What that does then is cause this acute lung damage, and we see that as the ARDS picture. On the other hand, the increase in the reactive oxygen species, which may also be occurring at the level of the pancreatic beta cells, the presence of the activation of the renin-angiotensin system may exacerbate the insulin resistance, and that then contributes to further hyperglycemia. We know that activation of the renin-angiotensin system also may lead to this vascular endothelial damage. Increasing the D-dimer fibrinogen increases the blood viscosity, and all that conspires to increase the thromboembolism and cardiovascular events, and therefore we get this increase in cardiovascular and all-cause mortality. The other thing that we must also not forget is that patients with diabetes are disadvantaged in terms of their lung dynamics. So we know that they do have a reduced lung function, in that they may have a low FEV1. They may also have peripheral airway obstruction and reduced lung dynamics. If there's autonomic neuropathy, which causes parasympathetic dysfunction, and that increases in the airway caliber at baseline, it may also impair the ventilatory response to hypoxia. It may reduce the mucociliary clearance as well, thus increasing the lung infection. And because of the reduced respiratory muscle strength, as a result of either neuropathy of the phrenic nerve, what you have is now a situation whereby somebody already has compromised lung dynamics, you have an infection, and that makes the outcomes even worse. Adding to that is the fact that obesity has also been shown to be a risk factor for severe COVID-19 infection. And as I've mentioned, a lot of our patients with type 2 diabetes are also obese. And the mechanisms for obesity are very similar to diabetes. You have this dysregulated hyperimmune response via the excess adipocytes. They too tend to have these compromised lung dynamics with reduction in FEV1 and the forced vital capacity, and also the diaphragm contractility. And as a result of increased thrombogenic potential, that also leads to severe outcomes from the infection. So we really have what we call the perfect storm, or the clash of the titans, where on the one hand, diabetes causes this compromised innate immunity. You have pro-inflammatory cytokines. There's already an underlying endothelial dysfunction. Diabetes, we know, is associated with a procoagulant state. Then there may be this reduced ACE2 activity that predisposes the lungs to severe injury and an impaired pulmonary function. On the other hand, COVID-19 is able to exacerbate stress, hyperglycemia, exacerbate insulin resistance, and we know it causes endothelial dysfunction. So it's the perfect storm for really having poor outcomes. So the other thing, so what we know so far is that there appears to be this bidirectional interaction between the virus infection and diabetes, but it's still unclear whether the virus directly infects the beta cells, or whether it is just a combination of this immune response dysfunction, inflammation, the increased coagulation that potentially triggers the development or worsening of diabetes. So we recognize that diabetes is associated with an increased risk for severe COVID, but does COVID infection lead to new onset diabetes? And this was first sort of mentioned in the New England Journal of Medicine as a letter to the editor in August last year. And the author of that letter said that it may be plausible that the virus may cause some pleiotropic alterations of glucose metabolism that could then complicate the pathophysiology of pre-existing diabetes and may lead to new mechanisms of the disease. Further evidence is now being seen in children as well. And this is a paper that was published quite recently in Diabetes Care, just April of this year. And the authors here talk about a spike in diabetic ketoacidosis in pediatric type 2 diabetes during the COVID-19 pandemic. So this was a large hospital in Los Angeles. And what they did was they looked retrospectively at their cases of DKA. And what they were able to see was that the rates of DKA in 2018 was about 9% In 2019, it was 3%, and then there was this exponential increase in 2020 of around 20%. So the questions then are, how frequent is this phenomena of new onset diabetes? Is it classic type 1 or type 2, or is it a new type of diabetes? Do these patients remain at a higher risk for diabetes or diabetic ketoacidosis? And in those with pre-existing diabetes, does COVID-19 change the underlying pathophysiology and the natural history of the disease? Now, there was another interesting article that came out in April this year in the Lancet Diabetes and Endocrinology. And here the authors of this article put forth a few highlights, and they said, the COVID-19 infection, like other infection, can cause hyperglycemia in individuals without known diabetes. And reports on the onset of type 1 due to COVID have been quite conflicting, and therefore they concluded that a causal association is probably unlikely. Then the data that is around the ACE2 expression on the pancreatic cells has also been quite unclear. Also, we're not really sure whether the beta cells express or can be induced to express the necessary receptors for direct viral injury and therefore lead to beta cell destruction. And then proving that there's direct toxicity to the beta cells will actually require histological evidence of beta cell loss and the presence of the virus within the pancreatic islet cells of those individuals that are infected with the virus. So they conclude, of course, that the available data that's available now on the effects of COVID-19 on the development of new onset diabetes are rather conflicting, and therefore further studies are needed. And that's exactly what the group of investigators led by Paul Zimmet from the Monash University in Australia with King's College London have sought to do. They've come up with the COVID-Diab registry in order to further understand the extent and phenotype of new onset diabetes that's defined by hyperglycemia, confirmed COVID-19 infection, and a negative history of diabetes. And the link for the website is there. So if you have your patients that are presenting with new onset diabetes and you think that this is worth reporting, you can actually sign on to that website and report the cases. So going now towards the management principles, and the first thing we need to do is appropriately risk categorize our patients, make sure that we offer them meticulous glucose monitoring and then medication adjustment. And that's important because we know that maintaining good glycemic control is key to reducing the risk for infections. And this is now a famous picture. It speaks 1,000 words. Well-controlled blood glucose correlates very well with improved outcomes in patients with diabetes. So the benefits of glucose control are really to improve outcomes during hospitalization and to improve longer-term outcomes in order to reduce mortality. And this can be done in hospital also by the use of continuous glucose monitoring. So what about some of the basic principles of best practices that we can offer our patients? Staying at home whenever possible, making sure that they follow all the sort of public health guidelines that have been reiterated so far, making sure that they wear the mask when they're in public areas, and making sure that we remind our patients at every opportunity that they increase their glucose monitoring and get in touch with us when they need to, and not wait until they've got either impending glycemic crisis or they've developed other sort of complications. The other thing is to remind them to focus on these self-care practices, so making sure that their dietary habits remained good. During the lockdown, we had a lot of patients that, because they couldn't go out to exercise, they were also ordering food, and many of my patients are coming into clinic now with having put on a lot of weight. So we need to encourage them to exercise, get enough sleep, and of course be aware of the mental and health issues anxiety and depression as well. For clinicians, we need to remember that we have to have an aggressive approach to maintain glycemic control, increase the outreach to our patients, and that may be through telemedicine if it's available to you, and to encourage this communication between us and our patients. The other thing that is important, because there was a time when there was this confusion about the use of the RAS inhibitors, these should not be discontinued in the patients that are on them, because there is no association that these would increase the risk for the infection. So, how can we help our patients? And to summarize, therefore, the best ways to prevent the infection in people with diabetes. Therefore, the vaccines are available now, and we should encourage our patients with diabetes to make sure that they're vaccinated. Most importantly, we need to make sure that they continue with their glucose-lowering therapies, continue to monitor their glucose and make sure that they have optimal glycemic control, and minimize their exposure to the virus as much as possible. With that, I think I've come to the end of my presentation, and I'd like to thank you all for your kind attention. And I'll pass it back on to our chair.
Thank you very much, Dr. Khadija, for the beautiful presentation. I think we will have a question later. We will move now to Professor Antonio presentation. Welcome, Professor.
Thank you. Thank you for the opportunity to join this. Oh, voila. Where is my? Sorry, I don't know where are my slides. Yeah, you see my slide?
No, Doctor.
Yes, Professor.
I think now you see. Correct?
Yes.
Oh, it's okay. Sorry. So I think that Dr. Afid just gave a wonderful, comprehensive overview of what is related to COVID-19 and diabetes. I will be honestly a little bit more provocative about the story of COVID-19. My focus is to share with you which kind of lessons we learned during this pandemic. These are my conflict of interest. So there is no doubt, as already underlined by Dr. Rafid, that when diabetes is present, the prognosis of COVID-19 is very bad. And also there is a huge contribution to the possibility to die when somebody has diabetes. So this has been really clarified. I'm just showing one of the several meta-analyses which are available on this topic. My agenda is focused on what we learn in terms of control of hyperglycemia, on the use of anti-diabetic drugs, and what about the use of ACE inhibitors and ARBs, about the use of corticosteroids, the never-ending story of hydroxychloroquine, and finally, the role of thrombosis has in the prognosis of COVID-19. What about the story of hyperglycemia? As already underlined, this is a key slide, but also we have to know that this was the first study clearly showing that the people with or without diabetes, with a good glycemic control, had a very high rate of survival. You see more or less 90% of the people with a good glycemic control had the possibility to survive to the disease. This was not the case if the control of hyperglycemia was poor. As you see, when blood glucose was higher than 10 millimoliter, the possibility to die was quite high. And okay, this is what happens during the stay in the hospital. But what about the effect of the previous control, before the hospital admission on the outcome? The story is not so very clear, I have to say. already has been presented the Coronado study, but in a different way. But also the Coronado study coming from France was showing that the previous level of A1C had no impact on the prognosis of people hospitalized for COVID-19. But this result has been questioned by another study coming from England, when on the contrary, it was reported that the level of A1C before the admission to hospital had a real impact, had an impact in worsening the prognosis. I can anticipate that we have just published last day a meta-analysis showing that the previous A1C control level really can impact on the prognosis when somebody is hospitalized. So it seems that also the control of hyperglycemia before the admission to the hospital for the acute phase of disease can have a role in worsening the prognosis. On the other hand, when we speak about hyperglycemia, the story is more complicated. For example, it was evident that not only fasting glycemia at the admission, but also the glucose variability, meaning the swings of glycemia during the stay in the hospital in people with or without diabetes had was worsening the prognosis in this population. So not only the presence of high hyperglycemia, but also the possibility of a huge glucose variability was having a role in worsening the prognosis. And finally, this is a study coming from Italy, again from PISA, confirming that high glucose at the admission is worsening the prognosis, but also, and this is true for people with or without diabetes. But for the first time, it was clear that the high glucose level was even more dangerous in people without diabetes than in people with diabetes having COVID-19. So it seems that hyperglycemia during the hospitalization or admission for COVID-19 is a very bad factor, a very bad prognostic factor for the exitus of the disease. However, are this information so new? We already knew, for example, this study, but I'm just showing one study for each point, but there is a huge literature about what I'm going to say, that it's already known that the level of A1C before admission to hospital for any acute disease does not seem to have a very strong role compared to the effect of acute hyperglycemia at admission. So this was something already new. As well, it was already new that the level of glycemia, meaning high level of glycemia, hyperglycemia, is worsening the prognosis during the admission to an intensive care unit in people with or without diabetes. And particularly, this is also true for people affected by chronic obstructive pulmonary disease, which we know is one of the main complications of COVID-19. So again, it was already recognized that high glucose level is worsening the prognosis in people with any acute disease. And also we knew that glucose variability can be very damaging for people admitted in ICU for sepsis. This is true in people with diabetes, and particularly in people without diabetes. So at the end of the day, we can say that what we are seeing, what we see in terms of hyperglycemia effects, meaning high fasting glucose at admission, glucose variability, and so on the prognosis is not new at all. We already knew this in any situation that which can impact in any acute situation, and particularly during sepsis. This is why because there is a huge literature showing the effect, the dangerous effect of glucose variability on diabetes-related complications, particularly cardiovascular ones. So at the end of the day, what we are collecting as news in terms of effect of hyperglycemia in COVID-19 is not surprising at all, because it was already recognized, well known before the pandemic in people admitted in ICU particularly for sepsis. And not to be arrogant, just at the beginning of the pandemic, I wrote this editorial suggesting, look at the date, it was just the beginning of the story, and I was suggesting that a fast blood glucose control should be mandatory during the admission for COVID-19 in the hospital, because based on what we already knew, for me it was almost clear that the hyperglycemia can impact on the prognosis. What about the anti-diabetic drugs? Maybe you remember that there was a huge debate what to do about the use of the anti-hyperglycemic drugs in diabetes to face the problem of COVID-19. Because what I mean, for example, it was suggested that the GLP-1 receptor agonists and SGLT2 inhibitors can increase the expression of AC2, so worsening the prognosis or favoring the infection with the virus. On the contrary, somebody suggested that the use of the DPP-4 inhibitors can be as protective against the infection. This was really, there was a huge debate, a lot of fear in diabetes, the people with diabetes, but now it's clear, this is a paper just published a couple of months ago, confirming that the results, the evidence suggests that there is no reason to change the therapy in the people people treated with anti-hyperglycemic agent until there is not a clear contraindication, but not because the COVID-19 is a contraindication, but because during the disease can emerge some sort of a contraindication. But there is no reason to change on the therapy. On the contrary, in the case of SGLT2 inhibitors, the GLP-1 receptor agonists, you must keep them because they offer a protective effect against the cardiovascular events, which we know are a very serious complication during COVID-19. What about AC inhibitors and ARBs? The previous speaker already started to underline this problem. You know that the story is related to the evidence that the virus needs to link through the spike protein to AC2 receptor. And evidence is showing in vitro that both ACE inhibitors and ARBs can increase the expression of AC2 receptor. And somebody, just again at the beginning of the pandemic, was raising the concern, are the patients with hypertension, diabetes, mellitus at risk for COVID-19 infection? Please pay attention. This was just a scientific hypothesis, not supported by data at that time. It was just published as scientific hypothesis. But the result was, I'm sure you know from your clinical practice, that many patients, there were a lot of fear. They were stopping the therapy for the hypertension. And nobody will know, never we will know the price we pay for this. People stopping a life-saving therapy just because scared, and never we know the effect on new cardiovascular events or other complications. And then we learn from this study again, from another study again, that these treatments were not only safe, but very often can be very somehow protective against the problems right during the infection. So again, an hypothesis was considered true reality, and then some problem with racing, just until we got the evidence that this was not true, that was not just, was okay, good and a scientific hypothesis, but not supported by any data and not confirmed by evidence. What about corticosteroids? Please, pay attention to this. These are the first available guidelines on the management of COVID-19 in the hospital. And the recommendation was corticosteroids are currently not recommended. Wow. We needed some time to understand that, on the contrary, particularly in a very serious condition, use of a corticosteroid was the key to save lives. This was the first report, then several others were coming in the literature, and they were really showing that the use of steroids was really a key strategy to prevent the death in people with the COVID-19 in a very advanced phase. What about hydroxychloroquine? I have to say that in this case, it's really a funny story. Sorry to say for this, but I think that nothing as the use of hydroxychloroquine in COVID-19 was more than debated. There were some very preliminary evidence coming from China suggesting a potential benefit of using hydroxychloroquine in the prevention of the disease, until two publications were showing not only they were not useful, but on the contrary, can be also dangerous. These two publications were published in the New England Journal of Medicine and the Lancet, respectively. So very top journals, until was found out that the quality of the data was really questionable, and both of the papers were withdrawn. And the story was open for a lot of time, and there was just a debate. And you know that some very well-known personalities were supporting without any evidence that hydroxychloroquine should be used in COVID-19. Personalities like Donald Trump, the president of the United States. So what I mean, somebody who is should be recognized to be a serious person. But the question for diabetes is more complex. Why? Because hydroxychloroquine may have a direct dangerous effect on the heart. And the heart of people with diabetes is usually not very good. And particularly in diabetes, there is a high risk of hypoglycemia. Hydroxychloroquine can induce hypoglycemia. It's a very good anti-hyperglycemic agent, if you exclude the side effects, of course. So if you combine hydroxychloroquine with the current therapy for the management of hyperglycemia, you really increase the risk to have a lot of episodes of hypoglycemia, which of course can be very, very dangerous. Finally, what about thrombosis? Now we know very well that behind all the story of COVID, people are dying because of a thrombosis. There is a thrombosis in the pulmonary, in the lungs, there is a thrombosis anywhere, and the cause to die is the thrombosis. And this is particularly true for diabetes. We know that in diabetes already exists a prothrombotic state, which is exacerbated, is increased in the people with diabetes during COVID-19 infection. You see in this paper, which the data of an increased level, particularly of D-dimer, which is a marker of activation of thrombosis. And with this data is consistent. That has been confirmed very often in people with diabetes. So thrombosis in diabetes, but also in non-diabetes, is playing a key role in worsening the prognosis, even leading to the death. Well, you know how did we discover the role of thrombosis in the COVID-19? We discovered because some physicians decide to not follow the recommendation of the health authorities to avoid autopsies. They made autopsies and they found out the story of thrombosis. And this finding now is saving a lot of lives, because you know, in any standard therapy for COVID-19, we now included this, a very important the use of anticoagulants, even high dose of heparin, for example. But this information was just coming because some physicians decided to understand the pathophysiological mechanism. And unfortunately, you can get this very often only if you make an autopsy, which was not recommended by the healthcare authorities. So at the end of the day, why this happened? I believe that there were several issues about this story of COVID-19 and diabetes, but also COVID-19 in general. The communication between different specialists has failed. Anybody who is an expert in diabetes already knew the story of a hyperglycemia and acute illness. But if you look, and I made this search in the PubMed, and no one guidelines coming from expert, not expert in diabetes, was considering the management, the key role of management of hyperglycemia in COVID. Clearly, there was no communication between different specialists. Pure scientific hypotheses were considered equivalent to true evidence, substantial proof. This was, for example, the case of ACE inhibitors, where just an hypothesis was considered true before any clear evidence, and we never know. I repeat, we will never know how many people paid for this. Some preliminary therapeutic data were interpreted without caution. This is the case, for example, for steroids in one way, or hydroxychloroquine in the other way. So pure hypothesis, preliminary results were considered true evidence and followed. But also, I have to say that all this situation is also driven by global debate in the media, with the excess information and much fake news leading around the world, people be confused and scared. And this is my opinion. This scenario outlines that facing this new COVID-19 pandemic situation, typical aspect of human behavior prevailed over scientific consistency with the sum of the consequences just I described. Which are the possible solutions? I believe that we need a solution because this pandemic does not seem to end so quickly. Probably we have to stay together to face this problem for a lot of time from now coming on. We need a good cooperation from all the players involved in this story, from healthcare professionals to the different professional bodies, to mass media and general public. But I have to say, whoever, any single citizen must be engaged in this story, because there is no way, if no one is not contributing, for example, accepting vaccination, or doing all the best to prevent the appearance of to be infected, we will not go out from this dramatic situation. So at the end of the day, my opinion, the lessons from COVID-19 pandemic, we learn first that as never before, we need evidence-based science before any kind of a decision or action to be done. We need a true communication. We need collaboration, but particularly we need to trust in each other, trust between citizens and healthcare authorities. Otherwise, all we are going to do probably will be out effective in facing this very dramatic situation, which is even more dramatic for people with diabetes, as already very well described by Dr. Afid. Thank you very much for your attention.
Thank you very much, Professor Antonio. We will open now for questions. I have a question to Professor myself. You mentioned, Professor, regarding hyperglycemia and worsening prognosis. But when we have like an inpatient diabetic patient, and we tightly controlled his hyperglycemia during hospital stay, would that affect his prognosis?
Yes, there is already some evidence in this sense, in this direction. There are some studies published, I think 2 studies published in Diabetes Care, showing it's still in a small number of patients, but in these studies it's clearly demonstrated that if you improve glycemia, if you normalize glycemia, you are able to improve the prognosis. Because also this is accompanied by dramatic decrease of inflammation, D-dimer, and so on. It's not only the effect of hyperglycemia.
Mm-hmm. I have another question for you, Professor, from one of the audience. You mentioned the systemic corticosteroid, but the question was if inhaled or nebulized corticosteroid would have the same effect, or would it be of any benefit for COVID patients?
Let me clarify. You must use steroids when the situation is quite advanced. It's not the case to use steroids just at the beginning of the disease. At least the guidelines are suggesting this. And the problem of the steroids in diabetes is very specific, because if you do not have diabetes, there is no doubt. No, use steroids because they can save the life. In diabetes, the story is different because, of course, you can worsen the glycemia using steroids, and then you have to face an extra risk for hyperglycemia. But the studies coming out, there are already a couple of studies are showing that there was a benefit. The use of the steroids in diabetes, when you control glycemia, you can save their life.
Okay, I will move to Dr. Khadija. I have a question to her myself. Doctora, you mentioned that we don't know if COVID directly caused diabetes or worsening diabetes. But from your experience, have you noticed that recovered COVID patients who were diabetic have difficulty controlling their diabetes after recovery?
That's a very good question. And in fact, what we are doing is following up our patients, those who had new onset diabetes. We must remember that we have a background of a lot of diabetes. So it could just be that these were patients that who already had unrecognized type 2 diabetes, for instance. And then when they had the infection, as you do with any other sort of infection, they came into the hospital and the diabetes was manifested during that time. Now, there are some patients that we've seen during hospitalization required very, very high doses of insulin. And then subsequently, when we saw them later on during follow-up in the clinic, they were able to get off the insulin completely and are now back on just oral hypoglycemic agents. There's some patients who've even been able to get off the oral hypoglycemic agents entirely. So it's a spectrum. The question is, we're still not sure for those who had new onset diabetes, say, was it triggered just by the infection? Or is it that these are individuals, because we already have a high risk, the prevalence of diabetes in our communities is so high that this is just an individual who probably never before had the opportunity to go and check whether he has diabetes or not, maybe because he was not very symptomatic, but because he's come into the hospital now, and this is part of the protocol, the patient has come in with an infection, they will have their hemoglobin A1C and their glucose tested, and then we detect that they have diabetes. So it's quite interesting. And we're really looking forward to say the results that will emerge from the COVID-Diab registry, particularly around this concept of the new onset diabetes that may be specifically triggered by the infection.
Okay, thank you, Doctora. Back to Professor Antonio. A lot of a question from audience regarding oral hypoglycemic agent in COVID. Specifically, there is a question about if there's any role for glucose sensitizer like metformin.
There are some reports suggesting that metformin can be particularly beneficial in the management of COVID, of patients with diabetes and COVID-19. There are some contradictions, I have to say, in terms that some reports are positive, some are neutral. Probably metformin is more safe than other drugs, for example, than sulfonylureas. And then if you compare these two drugs, you get the advantage of one compared to the other one. But what I mean, at the end of the day, the most important information that there is no reason to stop metformin, on the contrary, to keep metformin if needed.
Okay, I have also a question for Dr. Khadija. The question is, what is the risk factor for DKA and type 2 diabetes patient with COVID, especially patient who's on SGLT2 inhibitor?
Yeah, so we know that in patients, even without COVID infection, SGLT2 inhibitors can induce a euglycemic diabetic ketoacidosis. So if it's inappropriately prescribed in a patient who actually has more of insulin deficiency, you may in fact trigger diabetic ketoacidosis. So now when they come, if a patient was already on an SGLT2 inhibitor, if they are not hospitalized, you would not need to discontinue their therapy. When they come into hospital, depending on the severity of the infection, you know, are they requiring mechanical ventilation, ICU admission? Yes, we would have to temporarily discontinue the oral agents and put them on insulin, because those are patients also who will require to be on corticosteroids. And it's very difficult then to maintain their glycemic control on just oral hypoglycemic agents. One, because they're not as powerful as insulin, and two, there is a variability in the absorption of these agents. Patients may be vomiting, their food intake may be erratic, and therefore it's a lot easier and a lot more practical to manage the patients with insulin when they come when they come into the hospital with severe infection. So we've also experienced a lot of patients that have come in with DKA, but they were not specifically on SGLT2 inhibitors. The majority of these patients that actually presented with DKA, we also found had a concomitant pancreatitis. So they had an increase in their pancreatic enzymes as well. There again, putting this sort of hypothesis, does the virus, you know, affect directly the pancreatic cells and therefore causing this pancreatitis acutely and predisposing them to DKA? But we know that other infections as well may precipitate patients coming in with DKA. Quite often in patients with type 2 diabetes, when they have other infections coming in with a myocardial infarction, so any sort of stress situation, pregnancy, can actually precipitate diabetic ketoacidosis.
Okay, there is also a question for Professor Antonio. It's again regarding hydroxychloroquine. One of the audience asking if we have a very well-controlled diabetes and no other risk factor for cardiovascular or thrombosis, would you still advise for hydroxychloroquine?
No, because there is no evidence. So it's unfortunately, there is no evidence that is beneficial. And this, if the patient is well controlled, you give hydroxychloroquine, you just increase the risk of hypoglycemia. Because by definition, somebody very well controlled is very close to the normal level. And then if you have another hypoglycemic agent like hydroxychloroquine, you can precipitate hypoglycemia. So no, short answer, no.
Okay. Maybe the last question for Dr. Khadija. if a new onset diabetes was found in COVID-19, would it differ in the treatment regarding non-COVID patients?
So the simple answer would be no. You want to control the sugar by whatever means that you have, depending on what is the baseline A1C that they've come with. You might consider to put them on insulin. If they just have maybe low hemoglobin A1Cs, you may start, and they're not very ill, they're not in an ICU setting, you may give them oral hypoglycemic agent. So you would treat as you would treat any patient that you've diagnosed with diabetes for the first time. The management principles are not very different.
Yeah. Thank you very much, Dr. Khadija. Thank you very much, Professor Antonio. I have no further question, and so we will end this accredited webinar, and now we will have 20 minutes industrial symposium.
Thank you.
Thank you very much.
Thank you very much, Dr. Abdullah. Thank you very much, Dr. Khadija and Professor Antonio. Please let me know when you can see my screen.
We can see it. Go ahead.
Thank you very much. First, I would like to sincerely thank the Society for granting us this opportunity to share with you our latest evidence when it comes to SGLT2 inhibitors, mainly Empagliflozin, in the field of heart failure. Allow me please first to introduce myself. My name is Sarena Othman. I am the Senior Medical Science Liaison for Metabolism covering Gulf, Iran, and Pakistan. So basically, in our presentation today, we would be covering the latest SGLT2 inhibitors trials on heart failure, in addition to the latest guidelines and recommendations in both cardiology and heart failure. So as you all know, doctors, that the story of Empagliflozin originally started with the EMPA-REG outcome trial as mandated by the FDA to assess the safety of Empagliflozin on top of standard of care in patients with diabetes and established cardiovascular disease. So 7,020 patients were studied. EMPA-10 and EMPA-25 compared to placebo on top of standard of care. This was meant to be an event-driven trial with a median observation time of 3.1 years. The main primary endpoint was the 3-point MACE as mandated by the FDA. Moving directly to the results, so Empagliflozin, as per the EMPA-REG outcome trial, demonstrated a relative risk reduction of 38% in cardiovascular death. This reduction has been consistent for both doses, sustained throughout the trial, and most importantly, an early separation from the placebo arm has been proven. Moving to the hospitalization for heart failure, again, a 35% relative risk reduction has been achieved, consistent for both EMPA-10 and EMPA-25, sustained throughout the trial, and again, an early separation has been witnessed from the placebo arm. When it comes to the renal benefit, Empagliflozin did demonstrate a 39% relative risk reduction in the new onset or worsening of nephropathy, and this was defined by a progression to macroalbuminuria, doubling of serum creatinine, or initiation of renal replacement therapy, or death from kidney disease. So this data, the cardiovascular death reduction and the reduction on hospitalization for heart failure, did pave the road for the EMPEROR-reduced heart failure trial. The EMPEROR-reduced was a trial mainly studying the patients with chronic heart failure with reduced ejection fraction, mainly basing it on the left ventricular ejection fraction being below 40% and the elevated NT-proBNP. The patients that were studied in this trial were both diabetic and non-diabetic, so we wanted to assess the safety of Empagliflozin in patients with heart failure regardless of their diabetes at baseline. 3,730 patients were studied, EMPA-10 versus placebo on top of standard of care. Again, when we refer to standard of care, we are mainly referring to ACE inhibitors, ARBs, beta blockers, MRA, ARNIs, and diuretics. This was, again, an event-driven trial. As 841 events were met, the study had to stop with a mean follow-up of 16 months. So I would just like to highlight at first when presenting this slide that this is not intended at any time to be a comparison between the data of empagliflozin in the EMPA-reduced, comparing it to data of dapagliflozin in DAPA heart failure. The main objective of this trial is to present the spectrum of heart failure patients that was studied in both trials. If we look in depth into the patients, we can see that the patients studied in the empagliflozin study were sicker compared to that in DAPA heart failure, and this has been translated in the elevated NT-proBNP. The eGFR at baseline as the cutoff point in the EMPA-reduced was 20 milliliter per minute, and as well, if we look in depth into the medications that were given at baseline, we can see, for instance, that the percentage of ARNI was 20% compared to 10% in the DAPA heart failure study. Again, we are not intending to compare any data of EMPEROR to DAPA. We are just presenting the broad spectrum of patients that have been studied with SGLT2 inhibitors as part of giving hope for patients with heart failure that are still getting the standard of care, but still being dying or being hospitalized due to heart failure. The primary endpoint for the EMPA-reduced was the time to first event of either cardiovascular death or hospitalization for heart failure. The key secondary endpoint was the occurrence of adjudicated hospitalization for heart failure, either first or recurrent, and the eGFR slope of change from baseline. Additional exploratory endpoints were added to the study. They were the renal endpoints, the change from baseline in the KCCQ questionnaire, assessing the improvement in the quality of life in patients with heart failure, reduced ejection fraction, and the time to adjudicated cardiovascular death. Moving directly to the primary endpoint, so empagliflozin did achieve and meet its primary endpoint as a composite of cardiovascular death or hospitalization by heart failure with a relative risk reduction of 25%, absolute risk reduction of 5.2%, number needed to treat by 19%, and the results were statistically significant and clinically meaningful as well. When we look in depth into the primary endpoint and we look at the subgroup of patients that have been studied, we can see that regardless of the diabetes status at baseline and regardless of age, gender, race, baseline BMI, and the eGFR at baseline, the results were still consistent in favor of empagliflozin when compared to placebo on top of standard of care. Even if this patient is taking ARNI or not, the results from the primary endpoint when it comes to the composite of cardiovascular death and hospitalization for heart failure were still consistent. So even if the patient is taking an ARNI or not, he will still get the benefits of empagliflozin on top. Moving to the key secondary endpoint, and here we are referring to the hospitalization for heart failure, either the first and the recurrent, and empagliflozin again did meet this endpoint by achieving a relative risk reduction of 30%, statistically significant, and as well we can see the early separation from the placebo arm. Moving to the renal endpoint, and here we are mainly referring to the change in the eGFR at the baseline, and by this we can tell that empagliflozin did protect the kidney by slowing the progression of kidney disease with an addition of 1.73 difference in the eGFR at baseline in favor of empagliflozin compared to a placebo. Moving straight to the to the exploratory endpoints, and here we are looking into the individual components of the primary endpoint. If we look into the first hospitalization for heart failure, a 31% relative risk reduction has been achieved, and this has been statistically significant when it comes to cardiovascular death, and a pronounced 8% benefits or reduction in cardiovascular death provided by empagliflozin compared to placebo, yet it does not reach its statistical significance. Moving to the composite renal disease of end-stage kidney disease or sustained profound decrease in eGFR, this has also been achieved and met by empagliflozin with a 50% relative risk reduction and a 1.5 absolute risk reduction again, and this has been statistically significant. When it comes to the improvement in the quality of life as per the KCCQ questionnaire at week 52, empagliflozin on top of standard of care, and here we are referring on top of ACE, ARBs, ARNI, diuretics, empagliflozin did achieve an absolute difference of 1.7 compared to placebo. We talked about the efficacy when it comes to reducing cardiovascular death and hospitalization for heart failure, but again, we can never compromise the safety, especially that we are talking about compromised heart failure patients. So the safety of empagliflozin has been proven in the EMPA-REDUCE to be consistent compared to the EMPA-REG outcome trial and the previous efficacy and safety trials that were done. We did not witness any alarming increase in any of the vital signs or the safety alerts. So we can tell that we did not achieve any hypoglycemia cases. We did witness a slight increase in the hematocrit, and this even if it was a slight increase, this still counts in favor of EMPA, given that the majority of heart failure patients are known to be anemic. A slight decrease in the NT-proBNP compared to placebo, a slight decrease in weight, and systolic blood pressure. When we talk in general about the safety profile of empagliflozin, again, when being studied in the EMPA-REDUCE, so no difference between groups in the rates of either hypotension, hypovolemia, hypoglycemia, and no cases of ketoacidosis have been reported in the EMPA-REDUCE trial. Several mechanisms have been proposed to explain the benefits behind SGLT2 inhibitors on heart failure. There are different mechanisms. We can say natriuresis can play an important role contributing to those benefits. Reducing the preload and afterload and the reduction in LV wall stress can also contribute. Reduction in the interstitial edema can also play a role, and the improvement in the kidney function and the cardiorenal physiology can also contribute to all of those heart failure benefits. Moving straight to the latest cardiology and heart failure guidelines, if we start with the 2020 ACC expert consensus decision pathway, as you can see, the trend when it comes to the cardiology guidelines is to focus on the cardiovascular benefit, either the atherosclerotic cardiovascular benefits or the benefits that can be seen on heart failure and DKD. And as you can see, if the patient is not pregnant or breastfeeding, and if they do have a good renal function, the ACC 2020 are recommending to start an SGLT2 inhibitor with a proven atherosclerotic cardiovascular benefits on heart failure and DKD, and they have mentioned CANA, DAPA, or EMPA whenever appropriate. No dose titration is required, and in case any further adjustment of the A1C is needed to adjust other anti-hyperglycemic therapy. When it comes to the ESC, they did recognize the paradigm shift, and for the first time, we have evidence from several cardiovascular outcome trials that indicates the cardiovascular benefits from the use of SGLT2 inhibitors and GLP-1 receptor agonists in patients with cardiovascular disease or at very high cardiovascular risk. Moving to the 2019 ESC guidelines, in which they have clearly mentioned that the choice of drug to reduce cardiovascular events in patients with diabetes should have the highest priority based on the presence of cardiovascular disease or cardiovascular risk. Cardiovascular outcome data strongly suggests that SGLT2 inhibitors and GLP-1 receptor agonists should be recommended in patients with type 2 diabetes and prevalent cardiovascular disease, or at very high or high cardiovascular risk, whether the treatment is naive or already on metformin. In the 2019 ESC guidelines, when it comes to diabetic and pre-diabetic patients and cardiovascular disease, empagliflozin, canagliflozin, or dapagliflozin are recommended in patients with type 2 diabetes and cardiovascular disease, or at very high risk of cardiovascular disease to reduce the cardiovascular events. But when it comes to reducing cardiovascular death in particular, empagliflozin is mentioned clearly by name in the ESC guidelines as a recommendation in patients with type 2 diabetes and cardiovascular death to reduce the cardiovascular death in those patients. And this was mainly attributed to the Empareg outcome trial. Moving to the heart failure guidelines in the 2019 ESC guidelines, when it comes to the recommendations for treatment of patients with type 2 diabetes to reduce the heart failure risk, SGLT2 inhibitors, EMPA, CANA, and DAPA are recommended to lower the risk of heart failure hospitalization in patients with type 2 diabetes. And by this, I end my slide. Thank you very much, and I'm open to any questions, if any.
Thank you. All the questions were for the lecture related. No more question for you.
Thank you very much, Dr. Abdallah.
You're welcome. So we can end our session today. Thank you very much for all participants. Thank you very much for the support of this session, Serena. And we can end the session.